Greetings to our speakers of the day. We have two speakers today. Greetings to Apotheker Elida Zairina, M.PH, PhD from the Faculty of Pharmacy, Universitas Airlangga. And also good morning to Associate Professor Hanan Khalil from Trobe University, Australia. And also good morning to all ladies and gentlemen in this meeting room. Welcome to the World Patient Safety Research Week, Day 2, with the theme Medication Safety. I am Nindya Rifani, and I will be the MC and the moderator for today's event, starting from 11 a.m. and approximately it will end at 1 this afternoon. So without further ado, we have the speakers here and also the audience here. So to the operators, you may present our speaker's curriculum vitae before we begin. The operators, please show us our speaker's curriculum vitae. Okay, so today we have two speakers. Our first speaker is Mrs. Zairina from Faculty of Pharmacy. She will bring up the topic of knowledge, aptitude, and practice toward disposal of unused medication in community. And our second speaker, Associate Professor Hanan Khalil, she will bring up the topic medication safety in primary care. Okay. So our first speaker is a senior lecturer at Departemen Farmasi Komunitas, Community Pharmacy at the Faculty of Pharmacy, Universitas Airlangga since 2002. The operators. Hello, Miss Elida Zairina. Good morning.
Hi. Hi. Good morning, Nindya.
I hope you had a nice morning, nice day. Hello, Associate Professor Khalil. Good morning.
Hi, everyone. Good to see you here, and I'm looking forward to share some slides with you and talk about medication safety in primary care.
Good morning too. Thank you. It's nice to see you too.
Likewise, thank you.
To the operators, the curriculum vitae, please. Okay, so this is the curriculum vitae of our second speaker, Associate Professor Khalil from the Trobe University, Australia. Associate Professor Khalil is a registered pharmacist who has worked in clinical practice for several years in both hospitals and community settings in Victoria and South Australia. Her research focus is on improving quality of care to patients accessing services and health services quality and performance. Associate Professor Khalil is the co-editor-in-chief of GBI Evidence Implementation and a member of the editorial board of BMC Health Services Research. Associate Professor is also a discipline lead at Health Administration and course coordinator at Trobe University, Department of Public Health, Melbourne, Australia. She is also a consultant pharmacist from Mitchell House Aged Care Facility in Morwell, Victoria. She has received many awards, including as recent as 2016 as the recipient of the International Evidence Transfer Award from the Joanna Briggs Institute for the significant development of the Chronic Disease Management Center for 5 consecutive years.
Strategi ya, bagaimana mengurangi SKM.
The operators, you may present our speaker curriculum vitae. Associate Professor Khalil, you've been here before. You've been to Universitas Airlangga before, have you?
Yes, yeah, that's right. I gave a webinar on scoping reviews, evidence synthesis and scoping reviews before. So I'm delighted to be here again.
So this would be your second time here? Yeah.
Yes, that's correct, yes.
It's really nice to have you here.
Thank you. Good to be here.
To the operators, may present our first speaker curriculum ID before we begin, so I can introduce our speaker to the audience. Operators. Maybe we can talk as we wait for the curriculum ID. Hello, Mrs. Elida Zairina, how are you today?
Hi. It's all right, Nindya. It's good to see you. Hi, Hanan. I hope Melbourne is fine at the moment.
We're all fine, but in lockdown.
Well, yeah,
never ending story.
I heard that. All right, thank you, Nindya.
All right, so this is our first speaker curriculum YT. Let me introduce Elida Zairina. She will bring up the topic, knowledge, attitude, and practice for disposal of unused medication in the community. Our speaker is a senior lecturer at Departemen Komunitas, Faculty of Pharmacy, Universitas Airlangga, and has been a senior lecturer since 2002, or has been a lecturer since 2002. With many research interests, including patient safety. Her recent education, including as a Doctor of Philosophy, a PhD from the Faculty of Pharmacy and Pharmaceutical Sciences, Monash University, Australia. And the recent publication is Screening for Identifying Individuals at Risk of Developing Type 2 Diabetes using the Canadian Diabetes Risk or CanRisk questionnaire from 2021, very recent. So without further ado, let's start today's event with our first speaker, Mrs. Elida Zairina. The screen is yours.
Right, thank you so much, Nindya, for a very nice introduction. Good morning, everyone. I'm so happy to be here. That's today we'll be sharing a screen with Associate Professor Hanan Khalil. Welcome. I'll see you the first time. I'll see you online, I guess. I hope we'll see you more in the future. All right, so let me share my screen. So does anyone already see my screen? All right. So is the screen is available now, Nindya?
Yeah.
Right. Okay. So for today, that's going to share for the next 30 minutes. We're going to talk about topics that related to patient safety. About the background and then the medicine disposal programs. One study that we have completed that related to medicine disposal practice awareness and the take-home message. So we'll start with a little bit of background. That, as we know, that the pharmaceutical products are consumed and are produced every year. They're increasing, and they're using for healthcare products for diagnose or treating or prevent the health conditions. However, the use of prescriptions and over-the-counter products, although there is increasing globally, it is also expected to reach over 4.5 trillion doses in last 2020, and that was a 24% increase since 2015. Unfortunately, not all medications, they reach the patients or consumers. There are so many medications in large quantities that goes unused or expired. So the accumulation of the medication that kept in a household or in a family, as well as the improper of the disposal in unwanted medicines, they may result in inappropriate use of medicine sharing, or could be accidental childhood poisonings when the children can reach the medicine, and also could lead to the diversion of the medicine for illegal or illicit use. So now is the reason why is there unused medication? But probably most of the community or some of us never realized that there are unused medications. So the medications, they can accumulate or kept in the household for there are some reasons. But the first reason is because they feel there are already improvements on the patient's condition. Another reason is because the patients or community receive the medication in the bulk package, or they thought that the prescriber give too much medications or too many medications, and other reasons because of the death of the patient. The changing in prescriptions because the patients feels the side effects of the medications, and they felt that the medication they consume doesn't give any effect. So they just stop it, and that makes the medication is unused. Another reason is also because of the poor adherence for the patients. They stop the medications because they felt that they don't need more medications. They feel their conditions is better. They doesn't feel any symptoms anymore. And also because they feel if they are keeping or they are keep to taking their medications, they will feel adverse side effect. Or some of them probably didn't do an intentional poor adherence because simply they forgot to take their medication. There's a study that do a research on why many people keeping their unused or expired medications in their homes. Well, some of the respondents on the survey say that because of the inertia, it takes more effort to discard something, but then compared to just leave it or just put it in their cupboard or in their anything, they just leave it at home. And there is also some feeling that there's a natural inclination for people to save something that they think that will be helpful in the future, especially if the medications they like to keep is expensive, and they feel like, okay, or maybe I just keep it. Maybe I need it in the future. And well, this could lead that probably some of the patients, or probably among us, they just don't realize that it is not unsafe to keep the unused or probably the expired medication at home. So there are some concerns regarding why if we are keeping the unused medications or the leftover medication. Again, because some of the patients, they believe that if they are using these medications at the moment and it's served purposefully, they might be useful again in the future. For example, like analgesic may be the best example here, because sometimes people are often inclined to treat pain as soon as possible when they arise, just like they feel pain, they just like took any analgesic available at home. So they thought that it's better to keep analgesic as at home, whether it's not been used for a long time or maybe it's already expired. So people think that it's better to have medication at home. And one study said that sometimes it's not only analgesic that can be purchased over the counter by people or by community. There's one study that said that in 1/3 of 212 patients who underwent the dermatologic surgery, they were prescribed opioids. But only 41% of them, they dispensed the tablets that were used. 80% did not take all the prescribed medications because they feel they already doesn't feel anything. They feel like their symptom is gone. But more than half, they plan to keep their remaining tablets. So this is an opt-out. They just feel like it's better to keep it at home. And there's another systematic review that has been done recently. They say that more than a third of patients, they did not finish their antibiotic course as prescribed. And more than a quarter of patients, they took unused antibiotic for new infection. So they just took another leftover antibiotics because they feel they got a new infection. And there's also a study that say that the self-medication, but this is using antibiotics, is a common practice in some area or even in some countries. And then they just are treated using antibiotic as a sore throat when it doesn't need an antibiotic to treat. So, but then although there are some concerns to keep the medications, but there are also like concern regarding when we are doing disposal medications incorrectly. The unused and expired medications, when it's just like put it at home, because due to the lack of knowledge on proper medicine disposal, can pay a threat to the environmental contamination, such as on the water system. So if people doesn't know how to dispose their medication, the leftover or the unused medications correctly, it can make a harm to the environment. So for example, the presence of the antibiotic in weather has been associated with the antibiotic resistance. And in the long run, it can cause the genetic effects in marine life and also the human being. The long-term exposure of the pharmaceutical products in the environment will also have a negative impact, particularly to the vulnerable populations such as pregnant women, newborns, and children. So imagine if they just consume the water that are already exposed with the antibiotics leftover or any unused medications that could be harmful to the human being. When we are just stored or kept the medications, the unwanted or unused medication or any expired medication in the household, it gives an opportunity for people to misuse or abuse it whenever they have a chance. So if we, especially when we don't have a cupboard or the medications box that keeps the medications authorized from children, so any people who thinks that it's not harmful, they just can do it unintentionally to take the medication. So some countries, they have like some medicine disposals programs, because now like the leftover or the unused medications globally has reached a concern. So what are the programs? The medicine disposal programs is basically a program that the program is accept any expired, any unwanted or unused medicine from any consumers, patients, and they will dispose them responsibly according to the rules or to the guidelines. The programs in some countries can be used in person drops off, so people can just come to the community pharmacy, or they just can put it some medicine box or some trash for the medications, or they just like send it the medication. They send it to the community pharmacy or any area that is close to their living area, or they just using a permanent secure collection. Or if some like the local government, they're just coming to the door to door by the household and they just collect any unused or leftover medication or any expired medication, that they will do like dispose responsibly, and then probably doing like some of the recycling procedure according to the rules. And it can be provided by the government's collaboration with pharmacies, hospitals, clinics, or any community organizations partner with the law enforcement. So what is the outcomes, the benefit outcomes that if we do these kind of programs in our area. It could reduce the illicit of drug use. It can also reduce the unintentional poisoning because we want to keep the medication altered from children, any vulnerable populations, reduce the water pollution so people just don't throw any live or unused medication in their water system, and also improve the water quality. The other potential benefits or outcome is also increase the appropriate drug disposal. There are some rules that has been published by the FDA or any governmental organization about how to use the medicine or how to dispose medicines correctly. Some developed countries, they already have the medicine disposal programs. For example, in Australia, they have a national return and disposal of unwanted medicine that is called Narasumber, established by Australian government since 1988. This is to facilitate the safe medicine disposals for the community. So where the whole community, any patient, they just can dispose their unwanted and expired medications for free to pharmacies, and it's available that almost in every pharmacy in Australia. In the United States, in Denton, Texas, they have a program that is called Denton Drug Disposal Days. It's an event of the disposal of drugs that is conducted collectively, which is developed by the Denton City government and some researchers from the University of North Texas. And in Michigan, in the United States, they also have the medication return event. It's part of the annual pharmacy day of the Michigan Pharmacists Association since 2013, and they do it annually for hours, where people can just drop their unused medications and leftover medication or expired medication during the event. And then it's just like done by the volunteers coming from apothecary students, teaching staff, or from some university. And another example in Europe, in Malta, they have a medication return program that held in the community drugstores. The pioneer is a small village in Malta with a 3,500 population. So they put in the medication disposal bin in place with the drugstore in the front door, so people can just put their unused or leftover medication at the drugstore. So how about in Indonesia? Well, Indonesia have the similar program as well that we call it Ayo Buang Sampah Obat, or let's dispose of the drug trash. And then this is funded by the National Agency of Drug and Food Control, or BPOM, that it was launched in 1st of September in 2019. And this program was launched, carried out simultaneously at the same time in 15 cities, including Jakarta and Surabaya as well. And for a month, for the whole month, the public can dispose their expired medication waste in 1,000 pharmacies that spread across the 15 cities. But because the program was launched in 2019, and because of there are some obstacles as well, since the 2020 we have the pandemics, and the program probably is not running well at the moment. So, but this is as you can see that in the left side, there's a picture of the yellow bin that so people they just can come in to drop their unused medication or the leftover medication. So let's talk about there's an example of the study that we already completed about the medicine disposal practice awareness. So when we started to see, there are already a lot of studies that conducted, for example, in Kenya and Nigeria, that reveal that the most preferred disposal method, especially by the community, that if they just want throwing in the garbage bins, followed by flushing in the toilet. In other study, the respondents or the participants, they just kept kept the drug in their home because they were not really sure what to do with them, the leftover medications, and probably some other were planning to share with friends or family members. The study in Ethiopia, where almost 100%, that's more than 90% participants correctly understood that the negative impacts for inappropriately disposing unused or expired medication in the environment, but more than 3/4 of the participants agreed that there was like adequate information about the safe disposal practice regarding the unused or expired medication. So there are some study that already conducted, but the result is again like some area they have a positive impact or positive practice, but some area doesn't. So the study that we have completed is like we want to know the community knowledge, attitudes, and practice for using and disposing antibiotics. So we just focusing for one medication that was antibiotic. We want to know also the difference in knowledge, attitude, and practice based on their demographic factors and the relationship between knowledge, attitudes, and practice regarding the use and disposing antibiotics. So it was a descriptive study like conducted from February to June 2020, and we included any participants who above 18 years and who have stored or used antibiotics in the previous 6 months. And they agreed to participate in the study. We are using convenient sampling, and we are using a structured questionnaire that was developed by reviewing from different literature. So how's the result? So as we can see here, that we know that most of the participants have different knowledge regarding the gender. So the result revealed that female participants have better knowledge compared to male participants. And when we are asking about the knowledge between their occupation, they see that there's some difference that the students have more good knowledge compared to other occupations like private or self-employed participants. So when we are asking about what the medicine or what kind of medicine that they are kept at home, surprisingly that some of them they just keep antibiotics, pill, vitamin, analgesic, and then more chronic condition. And some of them, when we are asking, they are using some of the medication, and they just simply said that some of them they are using, some of them is already expired, and they don't bother to check regularly about the medication that they are kept at home. And when we are asking about these are like the question that we are asking to see their knowledge. And it's quite interesting. Like we know that most of the person, like more than 50%, they know that that antibiotics can be used to treat bacterial infection. That like nearly 100% participants have a correct answer. But then when we are asking like whether it is acceptable to start antibiotic for the future needs, only like almost 67%. Like the rest, it just doesn't have the rest has incorrect answer. Like they feel like antibiotic is okay to be kept at home. Like means like they just stop taking the antibiotics as prescribed by the doctor. And when we are asking about their attitude toward the antibiotic use and disposal, although like that, some of them they agree that it is important for me to apply antibiotic properly, but this is like they say that the resistance can be prevented by dispose antibiotic properly. Only like 58 participants, or nearly like 25%, like they agree. So this kind of attitude, and the last one is practice. When they are asking about do they complete the full course of antibiotic treatments, like always, like more than 50%, they say that they always complete the full course. And then when they are asking like stop using antibiotic if the illness has improved, and surprisingly only 20 people say that yep, they just stop using antibiotics if the illness has improved or the symptoms gone. And when we are comparing like category the level of knowledge, attitude, and practice among the respondents, well, although like they have a good knowledge, like approximately in the average, the more than 70% they have a good knowledge. The attitude also like they have a positive attitude followed by a good practice. But then again, this study needs to be see more carefully, like whether they are really doing the practice or because they just asking they just say yes when we are asking, or when they are asking as participants. So when we are comparing the level of knowledge between gender, like I said previously, that female participants has better knowledge likewise compared to the male participants. And when we are comparing the occupations, students have better knowledge compared to other occupations. Okay, so when we are see the relationship or the association between knowledge and practice, there are some significant relationship that knowledge has affected their practice. If they have a better knowledge, means like they have a good practice. But when we check doing the linear regression, that how much or how many practice can contribute to knowledge, we see that the knowledge can affect the practice by 35%. Yeah, while other can be influenced by other factors as well. So what can we discuss from this result? Well, our study showed that there are so many participants, or there are many participants that kept the antibiotic, vitamins, analgesic, and antibiotic at their home. And this is similar with the results from other studies conducted in Kabul, Ethiopia, India, and also another study conducted in Indonesia. Well, most respondents strongly agree that the community needed a particular program to dispose the antibiotic or other residual medications. And the same like in studies in India, where they saw similar results to the need for a specific program for the drug disposal. One study in Kabul that say that they chose or they prefer the government as the party that plays a role in shaping the public awareness for the managing and disposing of leftover or unused medication. And for this study, we know that knowledge and practice have a strong relationship, but also that we know that the knowledge affect the practice of antibiotic by 35%. That can be other factors influence also the practice. The behavior change is always not that easy because can be influenced by knowledge and attitude, but it's also influenced by the barriers like the social support from the community or the ability to realize why it's important to do such practice. But at the moment, the Indonesian Pharmacists Association is also working together with the government. They have education, like always giving education to the public. They have through the program that is called Drug Awareness Family Movement or Gerakan Keluarga Sadar Obat. So hope by this kind of programs that community awareness, especially public awareness about how to use and how to dispose the medications correctly can be increased. So what are the current projects that we are currently doing? We already nearly complete the projects about the consumer perception regarding the take back medicine program that launched by the Indonesian government or BPOM, and we already also have a household survey regarding the medicine disposal, and also we doing a survey in the pharmacies about their knowledge, attitude, and practice regarding the medicine waste disposal. So what are the take-home messages that we can share today? So the study conducted in different areas indicated not only the diverse practice of the disposal of unused medicine, but also represents that some of the participants were not fully aware of the appropriate approach. So a proper and safe disposal of expired or unused medication is really important to prevent the community or wildlife due to the environmental contaminations, the poisoning, the spread of antimicrobial resistance that associated with the inappropriate medicine waste disposal. Another message is we need to assist the community in managing drug waste, especially drug waste disposal programs, such as take back programs that must be developed. Probably the government and also the community need to like more actively to inform the community. And if we have a community that have a good knowledge, attitude, and practice, they are expected to become cadres in their surrounding area. That means that increase the active community participation in the drug medicine disposal, or particularly antibiotic, to reduce the antibiotic resistance. All right, I think that's all for me that I can share today. Thank you for your attention. I hand over to Nindya. Thank you, Nindya.
Thank you for the amazing presentation. Thank you, Elida, Zairina, so much. To the audience member, if you have any questions, you can submit it through the chat column. But the discussion would only start after our second speaker. But if you have a question, you can submit it now. Thank you again for the amazing presentation. Now we would like to start the next agenda, which is our second speaker. So I would like to welcome our second speaker, Associate Professor Khalil.
Thanks very much. I'm just getting my slides ready.
Okay, screen here.
Can you see my slides?
Yeah.
Amazing, excellent. Thanks very much for inviting me today to talk about medication safety in primary care. And what I'd like to present today is some of the work that I've been involved with in medication safety in primary care. Most of the work that I'll be presenting, it's really about the evidence that's out there. So in terms of scoping reviews and systematic reviews and what the medication safety look like, programs that are currently used in primary care. Obviously, primary care is very different to hospital services. So hospital and community, hospital in general, hospital services, they're very tightly knit communities. They've got their own agendas and protocols about medication safety guidelines. Whereas when you look at primary care, it's a little bit more open. It's not restricted, and sometimes it's not even policed by many people. Obviously, there is many stakeholders involved in primary care, medication safety for primary care. So there is the patient, there is healthcare professionals, and many healthcare professionals, and there are carers as well. So I'd like to start by introducing, and if you can type in the chat, if possible, from your experience, why medication safety is important to you as a healthcare leader, or a researcher, clinician, or even a consumer. So just to give you maybe 20 seconds or 30 seconds to think about this, and any reason that can come up, you can come up with is fine. So obviously many of us use medications from different perspectives, but why do you think we're very, we're very interested in medication safety in general? Nothing to do with the chat? Okay. So what I have is that there's many reasons why there is medication safety is important. So one of them is obviously medications are the most common health care interventions prescribed. So most of the time, patients go to doctors because they want to be prescribed a particular medication. It spans across different areas of healthcare, so not just hospital, but community pharmacy, dentists prescribe medications in Australia. We've got nurse practitioners, some nurses, podiatrists, and so on. Now, errors are common because as humans, we do make errors, so that's why medication safety is important. And some are potentially serious as well. And so healthcare leaders need to understand the issues that are involved in medication safety. Now, when we talk about medication safety, we talk about three different aspects of medication safety. So the first one is really about avoiding adverse drug reactions. So that's, for example, when a patient has an allergy to something or taken double the dose of something, then that's really adverse drug reactions. Avoiding medication errors as well. So that's when a human makes a mistake or even the patient double doses themselves and take a medication by mistake. Another meaning that we talk about is optimizing medication use by the patient. So that's really to do with adherence and behavior. So every time we talk about medication safety, we talk about all of these three aspects, and that's what I'll be discussing in the presentation here. So avoiding of adverse events, avoiding of errors, and then optimizing medication use by the patients. Now, medication errors are very common. You may be familiar that, they vary significantly in primary care, and I wrote a review based on what's available in the literature, and we found that some studies reported up to 80% of errors in primary care. And these were ranging from mild symptoms to severe symptoms, and resulting in mortality in a few cases. So why does this happen? So obviously there is a multifactorial aspect in medication safety. So there's advanced age, and as you get older, you're more likely to take multiple medications. Lack of patients' education also is very important. As Elida mentioned, that there is you don't expect knowledge from consumers all the time. So there is gaps in knowledge of many aspects of medications. There's also patients' comorbidities, which can also impact on medication safety. So obviously, when patients develop another condition that may affect what they are taking, or then also that can be a contributing factor. And transitions of care. Now, what I mean by transition of care is really when patients get discharged from hospital to home, or vice versa, or sometimes, to aged care facilities. So not necessarily they have all the up-to-date medications with them all the time. And that's when really some of the interventions that I'll be discussing to reduce errors would be very important in settings like that, in transitions between a hospital, a home, hospital, aged care, and so on. Now, with the consequences of adverse reactions, so there is lots of research that has been done about this, and including the research that I'll be presenting a little bit later on about the consequences of adverse drug reactions. But just to put things in context for you, now with that's just different statistics from the US, UK, and Australia. And if you can see here, there is lots of stats regarding the gravity of medication errors. So there is here 712 deaths owing to definitely avoidable adverse drug reactions per year in the UK. Now, adverse drug reactions cause about £98.5 million in the UK, which is a significant amount of money, considering that many of these adverse drug reactions can be avoidable. Another aspect is that, in the US, so you've got 1.5 million Americans harmed by preventable medication errors every year. And again, it does cause about $3.5 billion in hospital spending. That includes seeing, length of stay of hospitals, as well as seeing maybe GPs and going to emergency departments. Here in Australia, the majority of medication errors occur while performing routine tasks. So, and lots of patients can have died annually in hospitals just due to medication errors. So why this is important for us? So I'm just giving you an example. If you're not a pharmacist, I'll just take this slowly. So I'm just giving you here an example of somebody is taking a chemotherapy drug, an anti-cancer drug, and what could happen to them. So obviously you've got three different scenarios. The first one is a temporary injury, so a bit of abdominal pain, stomach upset, bit of hypertension, which can hopefully go away most of the time once the medication is stopped. However, with persistent use, and it depends on the dose, that can cause permanent damage, like diseases of the heart, lungs, or infertility. And in some cases, when you have severe bone marrow depression, that can cause death as well. So you can see from an example of a chemotherapy, giving just a chemotherapy for patient, that can actually result in 3 different scenarios, with the worst being death of a patient. What I'd like to focus on is, on this presentation, is that most of the domains in which patients' medication errors occur, they're to do with patients and public, so knowledge and public awareness, healthcare professionals, so either the doctor, the prescriber, the nurse, the pharmacist, being involved in an error, systems and practice, so some sort of a loophole in guidelines or in the checking or in discharging patients, or even in checking in community pharmacy when they give their own medications to their patients, and in medicines themselves. So that's obviously coming from look-alike medications or sound-alike medications, or medications that are new, drug interactions, and so on. The WHO has identified 3 major priorities to work in when it comes to medication errors, particularly in primary care. So the 3 things that we need to be aware of, and a lot of the work has been done in research is the transition of care. So again, that's going in and out of hospital or aged care or community setting. Identifying high-risk patients and situations. So that's when you've got a patient who's got multiple comorbidities, who's likely to have more than, a number of medications, has got some renal impairment or liver impairment, and you need to be careful with some of the medications you give, reducing the dose and so on. And situations where you've got multiple providers maybe, that are helping the patient. So you've got the specialist, you've got the pharmacist, you've got the doctor, and possibly a nurse as well, and a dentist who's prescribing, say, antibiotics or something like that. Polypharmacy, so polypharmacy, that goes to just the definition of that is anybody who's taking more than 5 medications at any one time, regular medications that is, so not PRN. So these are the 3 priorities that the WHO has identified as important areas where most of the research has been done to target and to reduce medication errors. Now, a lot of things have been, a lot of interventions and discussion have been tied up with these priorities and how to improve them using different interventions. So things to do with the transitions of care, and I'll talk a little bit about this in the review that I'm just about to publish in Cochrane. It does talk a little bit about healthcare professionals involved in outpatient clinics or primary care clinics. The role of the healthcare professional is really important when it comes to having effective interventions to improve medication safety. The role of technology as well, so having automation. I'm not sure whether it has reached Indonesia or not, but in Australia, we've got a lot of the dispensing is being done by automation, robots that scan barcodes and to reduce errors. Something else that we also need to be mindful of is how to measure error rates. And this is something that I'll talk a little bit about in one of the studies that I'm presenting, because obviously you need to have some baseline data to be able to build and see improvement once you do an intervention and see the outcome measures of that. Unfortunately, I'm not sure what happens in Indonesia, but in Australia and UK, and obviously in the US, we do have many organizations, whether hospitals or primary care, they've got incident reports. And incident reports are reports whereby the organization requires clinicians who are involved in medical errors to report some of these errors in writing and submit it to the manager. Just to keep track of what happened and to try and reduce the errors for next patients and so on. Unfortunately, as you can imagine, this hasn't been very, very successful because many clinicians are really worried to report a lot of mistakes that they have been involved with due to litigation or being fired from their job and so on. So having a look at the report, the incident reports for medication errors is not a reliable source at all for measuring error rates. The other downside of it as well is that obviously not every single error will get reported to in an incident report. Sometimes it's only the severe ones. So the first study that I'd like to talk about is the Cochrane review that I did mention earlier. And this has been published in 2017. However, we've just updated it. It's in peer review, and we've included about 10 more studies in the review, and it's about to be published shortly. It's having another peer review at the moment. So, the review really, we wanted to know the effectiveness of the different types of interventions to address medication errors in primary care. And we specified primary care to be places like GP practices, general practitioner practices, community pharmacy, aged care setting, basically anything not to do with a hospital. We've also included outpatient clinics because in Australia and some other parts of the world, outpatient clinics, that's when patients discharged from the hospital. Sometimes they have a review, they come back to the hospital, but only as an outpatient, not an inpatient. So we did include them in some of the in some of our studies. So we looked at 3 different types of interventions. We've classified them as professional, organizational, and structural. And we've used the EPOC terminology to that. So just having an example here of what a professional intervention is. So professional interventions, things like continuing education that healthcare professionals attend. So things like what we are attending at the moment, that is considered continuing education for clinicians. Drug education programs for physicians that run by physicians. So there are some also other drug education programs that are done by physicians to go in their primary care clinics and talk to them a little bit about what they can and can do and about new drugs and so on. Electronic health record system that provide information about drugs. So we did include that under professional system. So even if most of our doctors now in primary clinics, they use their own electronic healthcare systems, and a lot of them do provide some information about different drugs. We also included the things like health technology programs that identified patients who were at risk of, say, falls, and any computer-based ordering system that gives suggestion to pharmacists and physicians about dose reduction, all of that. So all of these clinical decision support systems that can come up into the electronic EMRs and then give you advice. So that was all considered professional interventions. The other type of interventions, they are organizational ones. And these ones were focused about having a professional providing a specialized service. So we've got here in Australia and a lot of other countries that pharmacists are involved in providing and leading some clinics and prescribing. And they are sometimes done out of a GP clinic, or sometimes they are done out of a hospital outpatient clinic. Revision also of clinical multidisciplinary teams. So that's when a pharmacist goes to someone's home to provide medication reviews. We've included that under organization because it's something structured that the government pays for. We also have included the telephone consultations. So these are interventions that are done by pharmacists, sometimes nurses, and it goes back to ringing the patient, telling them a little bit about medications and all of that. And most of these are done sometimes as a follow-up from a hospital discharge, or from a major procedure, or from even after a medication review that's done by a pharmacist. So we've included a lot of interventions a lot of these interventions under organizational interventions. Now, the last type of interventions were structural interventions, and there isn't much research about structural interventions. Now, structural interventions, they really rely on quality monitoring that could improve public health outcomes by increasing the willingness and ability of individual to practice interventions. So these are really big picture interventions that are done by the government to increase and engage the doctors as well as patients in taking up interventions. So that could be in the form of incentives done, or it could be a reduction in pay for private health insurance, or anything that's done as a public health measure to do that. And as you can imagine, because this is very broad and it's not very well publicly done, so we found only a couple of studies detailing that. Now, what we were interested in, so we thought about, okay, how are we going to capture medication errors? So the primary and secondary outcomes included the number of hospital admissions. So we wanted to know whether any of these above interventions that were addressing medication safety, whether they actually led to any hospital admissions or even visiting the emergency department in a hospital or even death. So that's really the measures that we set our review on. We've done a lot of searches with the help of a Cochrane librarian. So we searched multiple databases, grey literature, as well as clinical data registries. We've also looked through many of the theses and government reports. And we came up with a total of 43 studies in the review that I'm about to show you the results for. So I'll show you the results based on the intervention. So I'm bulking here the results based on the professional, organizational, and structural interventions. So the professional interventions here, and remember when I thought, so that's a little bit busy graph, but if you're familiar with Cochrane reviews, this is how we normally present the findings in a summary of findings for Cochrane reviews. So on the left-hand side here, you've got the outcomes that we are interested in, which is basically the hospital admissions. We've got the number of emergency visits and how many people died, mortality. And on the, in here, we've got the number of participants, total number of participants in the studies that we found, how many studies we found here, as well as the sort of, we graded the evidence to see how well the studies that we've included, using the grade evidence, whether they were the quality of the evidence based on the selection bias, the attrition bias, all of that, just to see how confident we are for the effect. Now, I don't want to dwell too much about this, but as you can see, obviously, and we've measured the relative risk. So as you can see, anything that has got a relative risk of more than 1, it means that the intervention wasn't really very effective because it did cross the 1. The other, and as you can see, even the confidence interval, for some of them, I mean, this one is a narrow confidence interval, narrowed, so that's for hospital admissions. And the way we measured hospital admissions, it was, we captured either the number of hospital admissions patients had or the number of patients admitted to hospital, because any one person can have more than 1 admission. So depending on what the outcome, what the paper was presenting. But I'd like you to have a look at this. So as you can see, everything was above 1. I mean, the relative risk for emergency visits was a little bit under 1.9. But again, there was a very wide confidence interval ranging from 0.6 to 1.2. And the evidence here was very, very low. So we had, it was a bit unclear about the actual evidence, whether it made a difference on emergency visits or not. So moving, and so ranging, if you can see here, we graded the evidence from very low to moderate, depending on the outcomes. So it basically, in a nutshell, it didn't really show us that organizational interventions had a good impact or good benefit or good benefits on any of the outcome measures that we want. Now, if you're into graphs, so again, you can see it from here. So that's the number of hospital admissions. Again, I'm showing you exactly what I've showed you before, but in a graph format. That's only for number of hospital admissions. So it was 1.24, well above 1, and which meant that there's no benefit, and the confidence interval was very, very high. So moving on from the others again, the number of people admitted to hospital, there was a total of about 130,000 participants in the studies that we've included, which were 2 studies. And again, the benefit is 1.01. So basically no benefit, and then despite the narrow confidence interval in here. And same with this one too. What I'd like to move on is the results for the organizational. So organizational, that's to do with medication abuse done by pharmacists, medication abuse by nurses, doctors, or even having a special clinic where patients came in, where a pharmacist or a doctor had tried to improve the medication setting in there. Again, we've had our measures of number of hospital admissions, number of patients admitted, number of emergency department, and mortality. So these were the outcome measures. We've had a huge number of studies. In fact, most of the studies that we've included in this review, they were really mostly about organizational intervention, because as you can imagine, there's lots of studies to do with pharmacists' roles in prescribing, and doctors and nurses in prescribing, administration, and dispensing as well. Now, again, I'd like to draw your attention to the relative risk. It's actually 0.9, 0.93, 0.8, 0.94. It's a modest benefit. However, when you look at the confidence interval, it's crossing 1, which means that still we're not quite sure whether professional organizations have got any benefit for reducing medication errors. Now, again, Mark, to draw your attention that most of our studies were really low quality. They had unclear selection and randomization methods. Some of them also had attrition bias, as well as not very much blinding too in some aspects. Now, this is the structural intervention. So the structural one, this is the one that I did mention to you before, the fact that there wasn't many studies involved in this. And that's when you include things like financial incentives for prescribers and patients even to be aware of medication errors. There was only like 2 studies in general, but one study reported on number of patients admitted. Another smaller one reported on number of people admitted to hospital, and only a small one reported on the number of emergency visits. Again, the evidence was varied from very low to moderate. And as you can see from the relative risk, the benefit of the trial, it was mostly 1 above 1, which meant that in fact, the intervention actually ended up increasing the risk of medication errors, which we don't believe it's the case. However, I'll discuss a little bit further on, but also given the fact that it's a very low evidence, we were not quite sure exactly about the true where the true benefit lies. So I guess to summarize this particular study, we found that based on moderate to very low certainty of evidence, the interventions in general that we've included really had made no difference to the number of people admitted to hospital or hospitalization or emergency visits and mortality. Now, most of these interventions were done in the UK and USA. So now this didn't really make sense for us. We thought, hang on. So a lot of this money was thrown for many interventions with no really benefit. So we wanted to look a little bit closely at our results, and we took 2 types of sensitivity analysis. Now, as I mentioned before, many of the studies were high risk bias. Some of them were clustered as well as randomized controlled trials. So we've actually done separate analysis by removing the high risk bias studies from the other ones, and also by removing larger studies that have got more weighting than the smaller ones. But we actually found that it's more or less the same problem. So there was actually lack of any benefit seen after we've removed these studies. It was also worth to mention that there was a huge variety in patients' conditions and level of comorbidity. And there was also a lot of details not mentioned in some of the studies that we've included, and the high level of bias that I did mention before. So really there was we didn't include any direct measure of reduction. So it just meant that we didn't really find any benefits by eliminating some of these high-risk studies. So what we did, we looked at some other studies where the study design was different. So instead of having an RCT, we looked at some other observational studies. And we found that there is not only that there is limited evidence of any benefit, but also we found that not many observational studies were included. And we got exactly more or less the same results as well. So we wanted to know a little bit more about what's happening. So with one of the discussion points that I've raised in that particular review is that maybe because we're capturing hospital admissions, emergency visits, as well as emergency visits, hospital admissions, and death, maybe they're not really good markers for medication safety errors. So maybe we should have been able to maybe have some other outcome measures, like, for example, number of medications reduced and so on. I will talk a little bit about this a little bit later in another study that we did. But again, that's another study that I did with the looking at medication safety programs. So this is a program. We defined the program as more than one intervention. So previously, the Cochrane review only relied on one intervention at a time, whereas I'm presenting here more than one intervention. So we identified medication safety program as a program whereby more than one intervention is done at more than one level. So either the organization level, clinician level, or a patient component level. And we've included a number of studies in here. I'll just show you this one here. So there was a study published in 2010. It had both an organization component as well as a clinician component. And the outcome measured here was the proportion of patients with a prescribing problem or a drug problem. And again, as you can see, the odds ratio is 0.71. So it just means that there is intervention was less likely to have the pharmacist intervention group was less likely to have a prescribing problem or a monitoring problem. The odds ratio was less than is 0.71, which meant that the intervention had benefit and with a relatively narrow confidence interval. Another intervention also involved another study involved two interventions. Again, they looked at the rate of high risk prescribing drugs, and that was indeed reduced in the intervention group than as opposed to the comparator group, and so on. So that's just some of the other studies, and I'm happy to have this available for you if you'd like to, in your own time, to look at some of these studies. So I'll just mention one of them, the 2015 by Ku. So again, there was a patient component intervention as well as an organization. And again, there was actually a significant reduction in the documentation errors in here, and overall management errors reduced significantly in percentage. So this particular scoping review included 9 studies, and most of them actually had different outcome measure about how medication safety was measured. So all of them measured things like rate of prescribing, administration, monitoring errors. Only 2 studies measured the number of errors reported rather than the percentage of errors. Now, again, it depends very much on the context, what you are trying to measure, and who's actually reporting these errors as well. So most of them are done on an audit-based study. Again, we've only included 9 studies, very small. However, there wasn't many other studies that really addressed the medication safety programs as such, not just an intervention. So out of this particular review, we found that multifaceted medication safety programs are definitely likely to include one or more of following intervention, and they are actually going to be most likely outcome for this program is the number of patients experiencing a medication error, and most likely to actually have some benefit as well. Moving on, this is the last study that I'd like to share, and it's about really what sort of adverse events or adverse drug reactions are presented in primary care, so that people can be, patients, clinicians can be mindful of when they talk to their patients. So again, that was a scoping review that was done just a year ago, and we included 19 studies, and there was many studies, population size ranging between 2,000 up to 33 million in one of the studies included in there, and most of the studies were published between 2003 and 2018, and most of them were published in developed countries such as the US, Germany, and Sweden. Now, as if you're a pharmacist, then you'll be able to make sense of this. So we did categorize the adverse drug reactions into drug-related allergic reactions or idiosyncratic reactions. We actually don't know what the cause is. Most of the drug reactions or drug classes were associated with reactions where the anti-TB drugs, anti-tuberculosis, anti-epileptics, antipsychotics, antidepressants, mood stabilizers, some antibiotics when they interact with other medications, and so on. Now, we also found that there was lots of errors involved with patients with advanced age, lack of patient education, patient comorbidities, very consistent with what's found in the literature above. So I guess what can we do to help from all of these studies? So these studies have shown that there is really not one intervention that will fit everything. So there's no one size that fits all. We'll probably need to have engagement from multiple stakeholders, professional regulators, professional leadership bodies to encourage reporting and learning from medication errors. We also need to think about development of a prioritized and comprehensive suite of metrics on how to best improve and measure medication errors. It's also important to have a development of a repository of good practice to share learning for everyone. And new research on medication errors should be encouraged and directed down the best avenue to facilitate positive change. Again, sharing knowledge is important, and working with patients and healthcare professionals. I just want you to, I'd like you to leave you with this, which is without accurate data, nothing will change. So an accurate picture of errors enables us to inform decisions to be made both in an organizational and international level. So obviously we need to have the numbers to be able to know exactly where the gaps are, and we can identify better interventions to address that. And that's just some of the references that I've used, not all of them. Yeah, and that's where my contact, if you'd like any more information on this. And yeah, and over to you, Nindya, for any questions.
Thank you so much for the amazing presentation, Dr. Hanan Khalil. I believe that there are some answers to your previous question, earlier question in the beginning of your presentation. For example, by Mrs. Inge Davanti, medication safety is the highest incidence. And then there's another answer from Rista Fauzi-Ningtyas, ensure the security and comfort during treatment. And also from Ms. Elida Zairina, that medication safety involves all parties and not only healthcare workers, but also patients. Those are some of the answers answering your previous question. So to the audience member, if you have any questions, whether it's for the first speaker or to our second speaker, you can submit your question through the chat column, or you can raise your hand and say and ask the speakers regarding your questions. So we'll be waiting for your questions. You can submit it on the chat column. Or maybe you say it and raise your hand. Missing a Damanti. Yeah.
Yeah, okay. Good afternoon, Dr. Hanan, Khalil, and Dr. Elida, Zairina. Thank you so much for your presentation. So I'm happy to see you again, Hanan. Good afternoon. Okay.
Me too, Ingi.
Thank you. So my question is, okay. I know that medication safety or medication error is happen a lot in many countries, especially in Indonesia. We have the highest incident of medication error happen not only in hospital but also in the primary care. So my question is, based on your research, Hanan, for Dr. Hanan, about the three different approach about it, whether it's structural or the organizational or professional. So based on that, if I'm not mistaken, so the structural approach one that has like more benefit. Am I right? Okay. And but unfortunately, that is the one that less likely being done until now, because it's involving like a big funding, like a financial incentive and the organizational quality monitoring. Okay, so my questions for you is, based on your experience in Australia, maybe you could share with us an example of patient safety regarding the medication safety in primary care program that has been very successful in Australia, whether it's involving the professional or organizational structural or involving like a multi-factor. That's the question for you. And for Dr. Elida, okay, thank you for sharing for the research, but if I could be honest, I never see the yellow bin in the pharmacy. I don't know whether Surabaya is involved in the city where the project is was done like that in 2019. So I think back if I reflect the research to my experience, I have so many medicine in my first aid box. So what is your suggestion? Do I have to, as a mom, especially because I want, if I go somewhere, I want to buy this for my children in case something happens. So I have so many different variety of like medication to for fever, for example. So what is your suggestion for like a mother or mother outside? Because I don't think that the father will care about that. So it's like the role of the mom. So what should I do? For example, do I have to review the medication like every 6 months or 3 months or a year? Or yes, maybe that's my question. Thank you so much.
Thank you. I'm happy to start if that's okay, Elida. Yeah. No, thanks for your question, Angie, and that's a very valid question. So, in my reference list, I've been involved in developing a medication safety program, actually 2 of them in 2 different organizations, and we've shown that we could actually reduce medication errors. So the way I did that is that we've implemented 2 interventions. Remember how I said multifaceted interventions are usually more useful than one single intervention. So we've developed a medication safety program based on putting together some guidelines for clinicians in primary care. So that primary care, one of the settings that I did work in was community healthcare setting. So that's when patients can go for the CGP in an outpatient clinic. Nothing to do with hospital, and we'll put some guidance together about how to deal with medication errors, what to look out for, things that clinicians that need to do once there is medication error. You know, what's the clear procedures about that. We also run some education sessions for all the clinicians about medication interventions. And we managed to, with these 2 types of intervention, we managed actually to have increased awareness of medication errors from the clinicians, but also a reduction in the number of errors caught in that area as well. The other program that I did also was involving indigenous communities. So I'm not quite know whether you know about indigenous communities, but in Australia and also in the US, we do have indigenous communities. So they are First Nations. And most of the time they don't really have good knowledge of, good socioeconomic level as well. So their education is quite not as highly educated as many of us. And also there is health literacy. They're very reluctant to go and see a GP unless if they are of indigenous origin and so on. So I worked with some of the leaders, the healthcare providers and Aboriginal care providers to develop some guidance for the Aboriginal healthcare workers about how to actually assess medication errors, what things to look out for. And I developed that guidance. We put it as an online guidance on the organizational website, available for everybody. So that's really kind of a structural organization measure. And the other intervention that we did, we ran training sessions that was actually catered for indigenous healthcare providers, because again, they were very different, not very different, but they were different to us, and we had to really highlight some more aspects of medication safety than them. So again, it was 2 interventions, one organization and one structural. So both of them worked, and we found that we've collected some, again, training knowledge has increased as well as medication errors. And actually both of them are already published, I think, a couple in the last 2 years. So feel free to access them or send me an email. They are in the reference list. But thank you. And over to you, Elida.
Thank you so much for the question. The first question, this is so true. Like I said before, like the BAFOM was launched. Sorry. Okay, so the BAFOM launched the program was in the drug disposal program or take back medicine program was in 2019, and then it's only lasted for a month. Because it's just like do it simultaneously among the 15 cities in Indonesia, and it's not all of the pharmacy involved. So they just are choosing randomly. Imagine like there are 1,000, they are just involving 1,000 of community pharmacies in Indonesia around in that 15 city. But in Surabaya, there are 700 community pharmacies. So there are only like 25, or I think it's 25 community pharmacies in Surabaya involved in the project. So, and it's all listed for only for a month. And then after that, there is no more follow-up for the program. And then in 2020, we were facing the pandemic. But the last time I checked, they're asking friends of mine, I said, okay, the program is just stopped temporarily. I hope it's not permanently, but they are trying to put it back again, because when even like it's only lasted for a month, there's so many people, so many consumers, they just drop their medication. It's just a small bin, but there's a lot of people, they just like it shows that so many people kept their medications at home. And that's leads to the second questions that, well, and this is like what happened when we are just as a mom. I can imagine that like it's better to, to have safe like a precaution before, other like than just have a medications when one of our children is sick, then we just like bother to buy the medicine. But then again, it's better for us to review regularly the medication, all of the medication that we are kept at home. Probably some medication we can still keep for a long time, like a common cold for children, probably as long as we saved it properly. And then it's just past the expired date, I think is good. But antibiotics should not have a leftover or unused at home, because antibiotic needs to be consumed like as prescribed by the doctors. It needs to be full course. So that's interesting, like lead to the survey that we are conducted among household, among the housewife in Surabaya. They say that they know that they should dispose their medications, but
more than 50%, they don't bother to do it. So they just kept it until, oh, when they are trying to use it, oh, it's already expired. So then that's it. So that's why we need to educate the community about this. Like it's not really safe to keep the medications a lot at home, especially those who are unused or leftover medications. Yeah, I think that's all from me. Hope that answer your questions. And then review your medication after this, and then we can see that how many medication that we are keeping it or we are keeping at home. All right, thank you.
Yeah, thank you so much for our speakers for the answers, and thank you for Mrs. Inga Davanti for the question. Yeah, we are still open for more questions. You can ask through the chat or by raising your hand. We'll be waiting. Perhaps there are more questions from the audience member. Seems like there are no more questions. I'm going to make sure if there are there no more questions from the audience. There's one question from Rista Fauzin Imtiaz. Prof. Hanan, how about the medication safety in nursing home in Australia?
I'm an accredited pharmacist, so I look after medication reviews in aged care, and I haven't done anything in aged care as such. However, I've looked at, and it was something that was published probably in 2011. I looked at because the reason because medication reviews are done all the time for residents in aged care, and the government pays for pharmacists as extra money to do medication reviews. So every resident in aged care, they end up having a review once every 2 years. Unless, for example, they can have more frequent reviews if they had more hospital admissions or change in medications and so on. The review that I showed, the Cochrane review, it did actually include residents as well. And what I've found is that there is benefit in doing medication reviews and reducing errors. However, there is no benefit really in reduction of hospital admissions or emergency visits or any of that. But if you look at the number of medications, for example, what I do, I try and reduce all the unnecessary medications. For example, if you've got a statin and a lady on a 90 or 92-year-old, I mean, there's no really need to have a statin for a 92-year-old. The evidence is just not there. So I would say that the medication errors are probably much less than in aged care, particularly when you've got pharmacists doing medication reviews there. And the study that I've mentioned earlier on, I actually found that 70% of the medication recommendations done by pharmacists in aged care, they actually taken up by the GP and the nursing staff, which meant that the bulk of what pharmacists normally recommend for changes of medications, it's actually being taken up. 70% is great. And I've actually, so that was my study, that was I think in 2011 and 12, but there's more further studies that have showed also increase of uptake. So I guess I'm not really concerned about aged care. Aged care have got a lot of other problems in Australia here when it comes to medications. So for example, access of medications after hours is a huge problem, particularly if some of these residents are palliative care patients and they are on really hard drugs like opioids and morphines. And so there is a problem in getting some of these medications after hours. I don't know whether I've answered your question. I think there is another question here.
There's another question.
Yeah, okay, that was it, yeah. There is another question about the barriers. Yeah, the barriers during this pandemic. In all honesty, because of this pandemic and we are in lockdown, it's really hard to do research in general. But pharmacists are really busy now because I'm not quite sure about Indonesia, but we are involved in giving vaccines as well. So pharmacists sort of are being taken up from the roles of administration and doing vaccines, and this is what the government has put in a lot of money in. I haven't explored the problems of medication safety during the pandemic, but it's certainly something that that it's worth looking at. What I've done though, and it's a publication that it's currently being peer reviewed in Journal of Human Resources Management. It was a special edition looking at the burnout and the emotional tiredness of pharmacists during the pandemic, and how everybody is very exhausted, and that's just because of the demands of PPE and the masks and what the community pharmacists are providing all the time, and also patients are quite worried about the virus, the medications, the stock even of medications. We had shortages at one stage. I guess that's also medication safety. If you can't get what you need, that's sort of a medication safety issue. So there has been definitely pressure around that, and that's going to be published, I'm hoping, soon. It's currently being peer reviewed first round, but it's a good paper. But there's actually quite a bit published, not just about pharmacists, but healthcare professionals and emotional labor. But the pandemic has definitely, I know a lot of pharmacists are currently working in large hospitals. They have been changed their roles from admin role and organization and putting some guidelines to going to actually doing clinical roles and making sure that we've got enough staff to patients ratio in the wards to be able to look after their medications and dispensing medications and all of that. And as you can imagine, if one staff gets infected, maybe half the department is out for 2 weeks until they come back from isolation. So it's been really difficult. So definitely redefining roles, prioritizing commitments, and so on. A great question, I have to say. Thank you.
Thank you for the answer. Perhaps there are any other questions from the audience member? You can raise your hand. Maybe the operators. Patient safety here.
Thank you.
Yeah, I'm going to make sure there are no more questions. The audience member. So we end this webinar today.
Thank you. I just want to say thanks very much for inviting me along. Really delighted, and thanks, Angie, for that. And I hope to see you again.
Yes, we really hope to see you again too.
Thank you,
Doctor. Okay, seems like there are no more questions from the audience member. Perhaps we could end today's webinar. Okay. Yeah, no more questions. All right. So now the event has now come to an end. And once again, we would like to thank our speakers of the day. Thank you, Dr. Hanan Khalil, and thank you, Dr. Elida Zairina, for the amazing presentation. And we would also like to thank our audience member and participants for staying with us during this event. We still have another webinar tomorrow afternoon. Tomorrow afternoon, we'll have another webinar with the theme COVID-19 and the impact on health systems. So we would really love it if you guys can come to tomorrow's webinars also. This webinar, the recorded version of this webinar, will be posted on our YouTube channel at Pusat Riset Keselamatan Pasien. So you can check our YouTube for this recorded version. So on behalf of the organizer, I would like to apologize for any mistakes done throughout the event. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you so much. Hanan, I'll see you soon,
Thank
Hanan,
you.
or see you
Yes.
again online.
Thank you. See you.
Thank you so much, everyone.
Thank you.